Hi, it's Steve Hargadon, and we're actually well into day 2 now of the Library 2.013 conference. Dr. Neil Pakenham-Walsh is our keynote speaker this hour. We're really delighted to have him. Neil, thanks for being here. The conference has received terrific support from San Jose State University as the founding partner of the conference. This is the 3rd year. Thanks also to Follett, Blackboard Collaborate, and EdWeb. You can see we've had terrific support from a number of partner organizations. Many more are on the website. This event is actually a part also of Connected Educator Month, part of the U.S. Department of Education program to help educators and librarians get connected. There will be a badge at the end of the session and information on a slide just like this will come up with the actual badge code. We have a small audience this morning. It is a Saturday here in the U.S. We know there are other competing live events, but for the 3 of you in the room, would you indicate where you're participating from? Up to the left of the map, you're looking for the star icon. Click on it twice, and then you can click on the map. I'm in North Carolina. I know Dr. Ho is in Florida. Dr. Pakenham-Walsh is in the UK. Oh, wait, you're vacationing. You're not in the UK.
That's right. I'm in Spain.
There you are. On the southern coast, I hope.
Barcelona on my last day of holiday.
How fun. Well, we appreciate that on your last day of holiday that you would take the time to present for us. So I'm going to turn the time over to you, and I'll be here helping in any way that you need.
Great. Thank you very much, Steve. And I'm delighted to be giving this presentation on healthcare information for all for the Library 2.013 conference. My name is Neil Pakenham-Walsh, and I'm coordinator of the Healthcare for Information for All by 2015 campaign. I'm also the chair of the D-Groups Foundation and the director of the Global Healthcare Information Network. And you can see my email address in case you want to contact me at the bottom there, neil@hifa2015.org. Just to introduce myself, my 2 main interests are to improve the availability and use of healthcare information in low and middle income countries, and to bring people together in large communities of practice to address complex health and development issues, of which improving the availability and use of healthcare information is one. I qualified as a doctor in London in 1983 and worked in the NHS for a few years as a hospital doctor. I also had brief episodes as a rural medical officer in Ecuador and Peru, where I discovered what it was like to be a professionally isolated health worker. And from 1990 to 2004, I worked in various posts to do with health information with the Wellcome Trust, the World Health Organization, and the International Network for the Availability of Scientific Publications in Oxford. And since 2005, I've been a director of Global Healthcare Information Network and the coordinator of HIPAA 2015. Here's the outline of my talk. It's in 4 parts, and then it will be followed by a period for discussion, open discussion among the participants. The first part is on health information poverty. Secondly, I'll give an overview of HIPAA 2015. I'll suggest some possible priorities for future action with regards to improving health information availability and use. And lastly, I'll invite everyone to join HIPAA 2015 if you're not already a member. We're looking at health information poverty. what is it, what are the causes, what are the consequences, and what can be done about it. So for the purpose of this presentation, when I think of health information poverty, I think of any situation where a citizen or a health worker does not have access to the information they need to protect their own health or the health of others. So it's highly contextual. Now there's a lot of things that can lead to a lack of the information that is needed at any particular moment. And these can include causes related to the end user, such as a lack of existing healthcare knowledge, stroke health education. In other words, what we do in terms of healthcare decisions and actions as citizens or as health workers is of course largely built on what we have previously learned in the past, as much as, if not more than, the information that we may have access to at that moment. But building on that, we may find ourselves in an information isolation situation if we do need information at that moment. We may have no phone to call for help. We may have no internet connection to look things up. We may not have a manual to instruct us as to what needs to be done in that particular healthcare situation. Or we may simply be unable to find or identify the information that is needed, even though we may have access to an internet or phone. So, for example, we may not be able to find the information in the right language, or it may not suit our technical level of expertise. It may not be appropriate to the available resources in our immediate environment. And it may not simply be in the right format. And then on top of all of this, there is exposure to misinformation that may be accidental or deliberate, or to biased information as occurs in much commercial-based information. So there's all kinds of things that can effectively lead to health information poverty in its widest sense. Another way of looking at this is to look at causes related to the failure of the global healthcare knowledge system. The global healthcare knowledge system is one way of looking at basically everything that happens with regards to the creation, exchange, and use of healthcare knowledge. So we can be thinking in terms of the research, the health research that underpins healthcare knowledge, the publication of that research, the indexing and the systematic reviews of that research, the guideline formulation by the World Health Organization and other organizations, and all the secondary and reference and educational materials that may or may not be partially or wholly based on evidence, on research evidence. And then of course there's a whole area of making information available, which is clearly the central focus of libraries and information professionals. But this representation of the global healthcare knowledge system, which by the way is adapted from an article that I wrote with colleagues and was published in The Lancet back in 2004. The reference is in a slide later in this presentation. And when we think about it, and when we think in terms of low and middle income countries, which is my particular area of interest, at every stage within this global healthcare knowledge system, where all researchers, publishers, librarians and information professionals act, at every stage there are barriers that are particularly strong in relation to low-income countries. And looking at the knowledge system in general, there are three systemic weaknesses within the system, which are also described in the Lancet article to which I referred. There's poor communication among the various stakeholders. There's poor understanding of the drivers and barriers within the system. And there's poor advocacy to convince governments and funding agencies to invest in publishing and information services, including libraries. And the consequences are dire. People are dying for lack of knowledge. A quote that I read way back in 1993 that stays with me, and I think it's as true today as it was then, is that of the approximately 50 million people who were dying each year in the late 80s, 2/3 could have been saved through the application of health knowledge. And here's just one example with childhood diarrhea. In India alone, 1,000 children are dying every day needlessly due to dehydration from diarrhea, due to basic errors in care from parents and health workers. We all know that almost all cases of diarrhea could be readily treated with oral rehydration solution or indeed homemade solutions. And a survey in Maharashtra state in India actually found that 4 in 10 mothers believe that they should not give fluids to their child or baby if their child has diarrhea. And this tragically is actually contributing to the risk of death of their child without them knowing. If they see a health worker, 1 in 3 of these children will be given antibiotics inappropriately, which do more harm than good in simple cases of diarrhea. In 2009, I did a review with my colleague Fred Bucacci on the information needs of healthcare workers in developing countries. And our conclusion was that there is a gross lack of knowledge about the basics on how to diagnose and manage common diseases, going right across the health workforce, and often associated with suboptimal, ineffective and dangerous healthcare practices. I'll now come on to an overview of HIPAA 2015. We are a global campaign and email discussion forum with more than 6,500 members in 170 countries, working together towards the HIPAA Vision. And our vision is a world where every citizen and every health worker has access to the information they need to protect their own health and the health of others. We launched in 2006 at the 10th Biennial Congress of the Association for Health Information and Libraries in Africa in Mombasa in Kenya. And we had a letter of support from the World Health Organization at the time that said, our goal is ambitious, but it can be achieved if all stakeholders work together. And these are the key words that underpin HIPAA, is bringing different stakeholders together. Our strategy is to promote communication, understanding and advocacy. You'll remember a few slides ago I pointed to these as being 3 of the systemic weaknesses of the global healthcare knowledge system. Looking first at promoting communication, we use a platform called D-Groups, and I'm currently the chair of the D-Groups Foundation as well now, but D-Groups has more than 2,000 groups, and you can find out more about D-Groups at the URL there, dgroups.info. HIPAA 2015 is just one of those groups. The reference underneath is an article that I wrote which describes the moderation technique that we use to add extra value to the discussions. And we do have very dynamic and lively discussions on the HIFA forums. which I think are largely thanks to various techniques that we use in our moderation of those forums. Here's a growth chart of the growth of the HIPAA 2015 membership. So we currently have 6,700 members. And the total membership of all 5 HIPAA forums, which I'll come on to in a moment, is now over 12,000. This map shows the distribution of the HIPAA 2015 members across the world. So you can see that we are scattered across most countries of the world, particularly English-speaking countries. And we have particularly high levels of population in the UK, in the United States, in Nigeria and India. And our members include the full range of stakeholders in the global healthcare knowledge system: health professionals, librarians, information professionals, publishers, researchers and policymakers. And the HIPAA 2015 has been a success and has been replicated in various forms. For example, we have a forum called Child 2015, which looks specifically at child health issues in low and middle income countries, which is in association with the International Child Health Group and with the International Society for Social Pediatrics and Child Health. We have a HIFA in Portuguese, HIFA PT, in collaboration with the e-Portuguese program at WHO Geneva. HIFA Azipnet French in collaboration with the Evidence for Informed Policy Network at WHO Geneva, and that group is rather specialized. It looks specifically at the information needs of policymakers in Francophone countries. So as yet, we do not have a HIFA French that looks at the information needs of frontline healthcare providers, and that is one of the new forums that we would like to create in the future. Similarly, we would like to do the same for Spanish. Lastly, you'll see on the bottom right-hand corner the logo for our first and so far only country-based network, HIPAA Zambia. Now you recall that HIPAA is aiming to promote communication, promote understanding and promote advocacy. So here we have a description of how we intend to promote understanding. Essentially, we want to build a picture of information needs of different health professional groups and how these needs can be met. And to do this, we are identifying short verbatim extracts from the HIPAA messages themselves and tag wording those and putting them into a database so that they are readily searchable. Anyone who's tried to look at an email archive will realize that it's very difficult to make sense of information if you look into the historical records of any email discussion forum. And this is our attempt to try to capture the experience of HIPAA members in a way that is easily usable in the future. Similarly, we want to bring together HIPAA citations, which are bibliographic references to health librarianship and information science literature, with a focus on the 57 countries, mostly in Africa, that are recognized to be in human resources for health crisis. And we are building this database so that it will have functional linkage with major databases such as the Human Resources for Health Global Resource Center, which is managed by IntraHealth International in the United States. Now, our database is in prototype at the moment. We haven't yet found the funding that we need to be able to develop it to its full potential. But even the prototype, which only has a few hundred knowledge objects that only has a few hundred HIFA quotations, has been used successfully by the World Health Organization to help inform a guideline on optimizing health worker roles to improve access to key maternal and newborn health interventions through task shifting. And as you can see, we have a testimonial here that says that we have the potential to be a leading source of practical and experiential data to help inform future international guidelines. Thirdly, HIFA aims to promote advocacy for increased investment in library and information services. And in order to underpin this, we worked with the New York Law School to assess the text of the international treaties around international human rights as related to access to health information. And we produced a white paper which the main conclusion of which was that governments have a legal obligation under international human rights law to ensure that citizens and health workers have access to the information they need to protect their own health and the health of others. This means that almost every government in the world that is who are signatories to international human rights treaties have a legal obligation to ensure that health information is available. It doesn't necessarily mean that the governments themselves have to be the providers of that information, but the governments have to provide the enabling environment in which providers of information can, and reliable information, can flourish. And conversely, governments have a responsibility to protect citizens and health workers from misinformation and from false information. We launched this year a program called HIPAA Watch, where we are identifying and recording examples of where individual governments are either promoting or blocking the availability and use of healthcare information. And an example of promoting health information, and there are many on our website, one is, for example, that India has made their national formulary for India available free to all its citizens, and indeed as a mobile phone app. And an example of blocking health information, I think possibly the worst example in recent history, has been South Africa in the early 2000s, where there was an AIDS denial which is said to have contributed to up to 300,000 deaths as a result of policies of the South African government at that time in relation to HIV/AIDS. And people, I'm sure, will remember the health minister at the time of South Africa, who was being dubbed as Dr. Beetroot because she promoted beetroot and garlic as treatments for AIDS, for HIV infection. Also, as part of our advocacy campaign, we have a number of country representatives. So we have 83 representatives in 40 countries who promote HIFA and help us to expand our membership. And here I'd just like to thank the many organizations that provide financial contributions to HIFA. These are some of the organizations that are providing financial contributions this year. We have a total income of around $30,000 US. We just have one full-time staff, and that's myself, and we have something like about 140 volunteers without whom we would not be able to achieve what we do. I'll now go into future priorities for action, and I think of these in three. Well, first of all, I think in terms of there are no shortcuts with regards to the global healthcare knowledge system. There are no magic fixes. There is a need to strengthen the global healthcare knowledge system, to understand it better, and secondly, to promote communication, understanding and advocacy. But then, of course, I'm now going to talk more in terms of specific solutions around improving the availability and use of health information with particular relevance to low and middle income countries. Now, over the past 10 years, I would suggest that there's been major progress in two areas. Firstly, there's been a huge increase in the internet connectivity and in mobile phone ownership across the world. The mobile phone explosion is particularly remarkable, and internet prices also are at last coming down in many low-income countries. Secondly, there have been a number of initiatives that have improved the availability, particularly of medical journals, and I think Hinari is worth flagging up as one, but there are others. But these are effectively short-term solutions. The long-term solution, I'm sure, is open access. And there has been a huge increase in open access, particularly in journal publishing over the last 10 years, which is to be hugely welcomed. Looking over the next 10 years, I think we'd like to see more open access. We'd like it to become the dominant model for research, but also the dominant model for secondary reference and educational materials. Secondly, we really need to be thinking more about equity in health information access, especially for those with low literacy, those with language barriers, those who do not speak English in particular, but also French, Spanish, are particularly disadvantaged, especially as more and more people come online. And also we need equity in health information access for information that is actually relevant and appropriate to low resource settings. Thirdly, there's a long way to go to help different end users from different groups with different languages to find the information they need when they need it. I think a good example of this is that on the Child 2015 forum at this moment, we're having a discussion about child protection and child abuse. And among the 2,600 members of the Child 2015 forum in the last couple of days, we've failed so far to come up with with an example of a simple guide that would be useful for, say, a community health worker or a primary healthcare worker in a developing country for the recognition and appropriate action if they suspect child abuse. I was unable, for example, to find anything in the Hesperian books where there is no doctor on this subject, and nothing also in the book Disabled Village Children, despite the fact that disabled children are at increased risk of abuse. But before I go off on a tangent there, I'll come on to number 4. And I think that as we increase the channels for information, such as mobile phones, we want to remember that those channels will be used by people who are motivated by profit or by other interests other than health. And therefore it's really important, I think, that mobile health and health channels generally are strengthened by ministries of health in developing countries, by the World Health Organization itself, Because if they don't get a handle on the channels of information, then you can be sure that the commercial interests will get in there, and the commercial interests may win out. Fifthly, and this is a question mark, I wonder whether there should be a shift away from the emphasis on behavior change. This is particularly in relation to health education and information for citizens, and towards empowerment, by which I mean to make it easier for citizens to be able to find the information as and when they need it. 6, do we perhaps need a shift away from our current paradigm of research into practice towards one where we are more recognizing the existing knowledge of different health end user groups and building on those? And 7, I think that there is still a big role to play for expansion of digital health libraries, which are organized in a way whereby you can go in and identify yourself as a particular end user group and find the information that is appropriate for you for that particular situation. This slide simply shows further reading, so it's really as a reference to come back to if you'd like to when you see the recording of this session. And lastly, here I'd like to invite all those who are in the room to join HIPAA 2015 if you're not already a member. Indeed, become a HIPAA country representative and think about using HIPAA as a basis for your dissertation if you're a student. There are quite a few students now who have used HIPAA in this way. And I'm now going to pass it over back to our moderator for the discussion. And thanks very much.
So that was so interesting. I'm clapping, which I do by hovering over the smiley face and then clicking on the applause. There were a number of questions that came up in the chat, some from me and some from others. I think if it's okay with you, I might start with this question of the difference between access to information and cultural willingness to use information. How do you address sometimes the cultural inhibitions to practice a good health practice?
I think that if there is cultural unwillingness to use the information that you as a health information provider are providing, then there is something wrong with the information you're providing or the way that you're doing it. In other words, it's largely the responsibility of the health professional or the communicator to get it right. I would bluntly put it that if health information is, if a person does not feel that health information is useful to them, then that health information by definition is not relevant to that person. So there needs to be, so the onus is on largely on the health information provider to repackage that information and rethink the way that they're making that information available.
That's a fascinating and great answer. How big a problem is the misinformation?
The misinformation is a huge problem. Firstly, there is misinformation that is associated with commercial gain. And there are, if we look, for example, at Big Pharma, the pharmaceutical companies, now we need pharmaceutical companies, obviously, to create pharmaceutical products. But at the same time, there are huge problems with regards to the ways in which pharmaceutical companies promote and market their products. Many, if not most, pharmaceutical companies have actually been found to break the law on many occasions. The second area, a second example is misinformation that is associated with ideology. And I think a good example of this is the polio vaccine in Nigeria and Pakistan, whereby a myth prevails that polio vaccine is a plot by the West to sterilize Muslim children. Now this myth clearly is dangerous. It was discussed on a Nigerian radio show, and it has been said, although I don't know the evidence, that this may have been a factor in the killing of 9 Nigerian frontline community health workers, polio vaccination workers, in northern Nigeria, which was very tragic. That happened at the beginning of this year, and at the end of last year there were similar killings in Pakistan, and let's hope we don't have any more of those.
Neil, what about the? Sorry.
Then the other. Sorry, I was just going to say again, for the misinformation is the misinformation that was promulgated by, I think it was Duisburg, and that was taken up by South Africa in the early 2000s, as I mentioned. That was misinformation about and denial of that HIV/AIDS was to do with a virus, which led to health policies in South Africa that directly or indirectly led to hundreds of thousands of deaths, according to estimates published in the Lancet some years ago. So those are just a few examples, but there's also inadvertent misinformation, and of course, unfortunately, the world is full of inadvertent misinformation. This is information, for example, in newspapers or in the mass media, where the journalists may not have the resources or the background knowledge to be able to be able to distinguish one thing from another, and therefore what comes onto the page for the reader is not correct. There's also a whole raft of publications that are done on a shoestring in resource-poor countries, which for the very reason, partly for the very reason that they are being done on a shoestring, contain errors. So misinformation comes in very many forms, and it's a huge issue. It's also very difficult, if not impossible, for an ordinary person to be able to look at 2 pieces of information and say, this is good information, this is bad information. This is one of the things that one would hope that tools like Google, for example, would be able to be better at doing this, because at the moment, even if you've got an internet connection, and even if you speak English and are fairly well educated, you can put in a medical question into Google, and of course you'll get several results, some of which will be reliable information and some of which will not be reliable. And many people will not be able to.
There have been a number of articles that I've read recently that have talked about the impact of an individual's family or social network, cultural network on their health. Has that been something that you've looked at?
I think that I think that I'm not in any great way, but there are various areas. There are, for example, the ways in which families and social networks and culture can bring with them beliefs that some of which may be beneficial, some of which may be indifferent to health, and some of which may be harmful to health. So there's lots of cultural aspects that can be either beneficial or harmful. I mean, an example of harm, well, one physical example is female genital mutilation, of course, and but a more sort of psychological example is if a child has epilepsy or if a child has a learning disability, then they may be shunned and stigmatized from their social network, from their community. I think another area that's quite interesting to look at is the area of children as agents for health. And one of our members on the HIPAA forum, Claire Hanbury, is doing a project on this subject, whereby children, especially in low-income countries, may very often be the providers of care for either their siblings or indeed their sick parents. And there are also often, in rural areas, I think particularly, they are often, when they're exposed to school education, they have the potential to be health educators within their own communities. And I think that's quite an interesting
thing. That's really interesting. So Rose wanted to know, is HIPAA 2015 helping to provide technology to access the developing database/healthcare information to practitioners in low and middle income countries?
I didn't quite catch that. I'm going to have to scroll up to see if I can find the question. Is HIPAA 2015 helping to, I've got it. Is HIPAA 2015 helping to provide technology to access the developing database healthcare information to practitioners in low middle income countries? No. Well, there's HIPAA 2015 as in the 6,700 individual members of HIPAA 2015, and those members include people from the World Bank, from the World Health Organization, from Ministries of Health, from UNICEF, from Save the Children, from different libraries around the world, and so on and so forth. So each of the individual members of HIPAA 2015 is doing something, is working within the healthcare knowledge system, and many of them are providing technologies, working in mobile health, and so on. HIPAA 2015 essentially as a secretariat is, as I mentioned in my presentation, it's run by a very small organization with just one staff, myself, and 120 volunteers. Now, my work is essentially to provide a discussion platform, in fact 5 discussion platforms, for people to interact and to make connections, to learn from one another, and so forth. And secondly, to provide a database, which it's important to recognize that we're not trying to create a database of health information. This is something that is being done by many other people in many other different ways, of course. What we're trying to do is to simply make the discussions on the HIPAA forums available in a database format so that they're easily usable for people in the future. So it relates more to do with what people say on discussion forums about health information needs and about ways of meeting people's information needs, rather than about do we give drug A or drug B to somebody with this particular clinical situation. So I hope that answers that question. I mean, the whole area of improving the availability and use of healthcare knowledge is something that goes way beyond technology, I would say. In fact, there are, and that's what I was touching on when I was saying there is no easy fix. Technology is a huge enabler for us to be able to do much more than we have been doing in the past. But even now, there is a role for the so-called old technologies, for radio, for television, for newspapers, for dance, for drama within communities, for simple passing on of information by oral tradition. These are things that should not get pushed aside. They should be built on.
Neil, did you see the question about the use of this kind of technology, the virtual meeting room? Is that a significant part of your organization?
Yes, we do. We do use Blackboard Collaborate, and we have had 2 meetings this year using the Blackboard Collaborate, and we've found that it's useful, but just like we're having at the moment there's only 6 of us in the room here, and we've often found that we've tended only to have about 20, 30 maximum people coming into the room at one time. But it is a useful tool to be able to use in addition to both the email discussion forums and, of course, face-to-face meetings. So we've had 1 face-to-face meeting in 2011 at the BMA in London, and we're having our 2nd one next year in Dar es Salaam in Tanzania.
So Rita asked if there were policies that the U.S. State Department should advocate relating to telecom and internet in particular countries or regions.
Are there policies that a State Department should advocate relating to telecom and internet? Well, I don't know what the leverage is of the US State Department with regards to the prices for telecoms and internet in other countries, but clearly any influence that the United States can bring to reduce the cost of internet access for especially low-income countries and middle-income countries, that would be hugely welcomed. But I would imagine that those costs are largely driven by market forces, and perhaps that the U.S. State Department doesn't have huge leverage on it. But the prices for internet access in, say, sub-Saharan Africa in the last 10 years have been astronomically high. They've been much higher, not just relatively in terms of relative to income, but also in absolute terms. They've been much higher than they have been in Europe and the United States. And indeed, there's a lot can be said in terms of free access to publications is much more common in, I would say, in Europe and the United States as well. A good example is in the UK. There's a fantastic publication called the British National Formulary. Now this is probably is one of the best independent, reliable drug prescribing guides, and it is made available free to every person in the National Health Service. throughout the United Kingdom. And yet it's not available. Meanwhile, prescribers in low-income countries generally and more often do not have access to reliable information and have to make do with old notes or with the leaflets inside packaging from pharmaceutical companies. So there's a big difference there.
It seems that your annual budget is quite low.
Yes, our annual budget is $30,000 a year, and that funds my full-time salary plus office costs and so on. I don't do a lot of travel, certainly not within that budget. If I do travel, it's by invitation. Most of our funding has come from the British Medical Association, which provides £10,000 a year. That's about $15,000. And the rest of our funding comes in small amounts from a subgroup of our HIFA supporting organisations. Now there's 185 organisations that have publicly committed to support HIFA, but only about something like about 26 organisations also provide a financial contribution. And so, of course, what we're seeking to do now is to double our annual income to something more like $60,000, in which case we would be able to bring in expertise and help to develop the second area of our program, which is the HIPAA Voices database. In addition to looking at opportunities to launch new forums in Spanish and French, and possibly other languages too. We're also looking at the possibility of launching forums in other countries, because our work with HIFA Zambia has gone very well indeed. We have a link there with the Zambia UK Health Workforce Alliance, and we hope to be able to do similar work with other organisations in other countries. So yes, it's not very easy to get funding for this kind of networking activity because it's quite difficult to measure. We did have a major external evaluation of HIFA 2015 was done in 2011, and it concluded that we did a remarkable amount of activity, that we achieved a remarkable amount on minimal resources. But we haven't been able to translate that as yet into substantial funding. But it will come eventually. Another point to mention is that although we're called HIPAA 2015, where we are in the process of rebranding to become simply HIPAA, whereby the HIPAA Vision is, as I described earlier. So we move away from what was a time-bound goal of HIPAA 2015 to a non-time-bound vision of HIPAA, under which umbrella we are discussing with our members about individual HIPAA SMART goals. So that's specific, measurable, achievable, relevant and time-bound. And our first SMART goal is we call MHIPAA, and that's the first one that we've defined, and it relates to mobile healthcare information for all.
We probably have time for one more question. If someone has a question, please feel free to put it in the chat or to raise your virtual hand. I think we're probably done. That was really fascinating. I'm so appreciative of your taking an hour to tell us about HIPAA 2015.
You're very welcome, Steve.
Thank you.
Thank you to all. Thank you to everyone for yes, thank you to everybody for